reasons. Get up, guys. Give me some time. Okay. 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 All right. Can you see my slide? All right. Okay. There you go, Christelle. Thank you. As- Crystal, thank you. I see you. There you go. All right. So, reasons for using toric contact lenses, of course, refractive astigmatism, spherical contact lens failed to mask in the form of masking, correct? I explained about masking, correct? Yes. So, RGP lenses induced residual astigmatism, meaning to say if it's corneal, that is not in, for example, it's not in the manifest. Therefore, you might want to have soft toric. RGP lenses, of course, cause discomfort. Then soft toric is the first choice. Now, visual compromise from residual astigmatism, unsatisfactory VA with best sphere, high sphere to cylinder ratio, or RGP is not tolerated. Those are toric soft contact lens indications. When do you give that? Because of this. Correct? All right. Now, we have the criteria for use. Degree of astigmatism, of course. Ocular dominance. Viability of the alternatives. Assessment of the patient's visual needs. Hey, toric assessment, which you have done, correct? You've done this, right? Good fit, full corneal coverage, good centration, movement, quick to return when axis is mislocated. Tight, again, good centration because it's not moving, initially comfortable, little or no movement, slow to return to its axis if mislocated. Then loose, excessive. Because it's excessive, lens awareness is the problem. Discomfort right away. Lens orientation unstable and inconsistent. So of all the three, the worst is to have a loose fit, right? Okay. Now, fitting method, we have your special spherical trial lens for toric design, spherocylindrical over refraction, and the compensate for the lens orientation. The next is toric soft contact lens trial lens. As a matter of fact, in Cebu doctors, this is what they do. They have toric soft contact lens or toric soft contact lens trial lenses. Okay, which is a lot easier when it comes to trying out before dispensing. Next is empirical prescription by computation, correct? Which is the easiest and the fastest. But then again, accuracy may not be, it's not guaranteed, correct? All right, so for toric, the fitting full corneal is about 0.2 to 0.5 millimeter movement. You can have an error on large side with respect to total diameter, of course. If HVID is 10 and what's available is 14, that's we can see the error is large, right? Good fit, quick to return if mislocated. Tight fit, slow to return. Loose, again, unstable and inconsistent. Measurement of rotation, have we seen this? Have we observed this? The reference mark at 3, 9, and 6. Crystal, what did you observe?
Nakikita po namin sa split lamp yung reference mark, like parang horizontal po siya.
Okay. All right. Okay then. So this is your reference mark. Have you seen those marks? Others may have seen it. Others did not see anything. That's why it would be nice if you can do your research. Actually, I just Google it and they will provide you with what kind of reference mark you are looking at. All right? So far clear?
Yes po.
Okay. Next. Predicting lens rotation. I already taught you, Lars, correct? Correct? And then I also told you that average lens rotation is 5 to 10 nasally. However, large individual variation exists. You have your cats, correct? This is cats. Anti-clockwise and clockwise, correct? Next,
Yes,
predicting lens rotation. We understand that the upper lid is dominant stabilizing component. With respect to rotational influence, oblique is greater than with the rule, which is greater than against the rule. So this is how you see it. Okay, this is your cats. You already know cats, right? Do you have any questions about cats? You don't? Okay. All right. How about toric fitting procedure? So this is the procedure that I want you to understand. First, you measure the refractive error and the vertex distance, correct? We did this through computation, correct? The vertex distance when it comes to spectacle to contact lens, correct? The lens power. Okay, select toric lens design, select trial lens power to match, meaning to say the computed ones if there's a need to compute, and then select the base curve or the lens diameter, correct? Then measure the meridional orientation as for dislocation. Then compute for the final prescription including axis compensation. Are we clear with this 1 to 6? All right. Now, physiologic consideration. Complications such as corneal edema when there is inflammation, and the vascularization known as the neovascularization due to hypoxia, right? If problem occurs, use high water content, which is 55 or greater. Now, if problem persists, you would notice the best is an RGP should you have any complication when it comes to permeability. Are we clear on that? So meaning to say, RGP also has its advantages and of course disadvantages. Soft contact lens also has its advantages and disadvantages. Correct? All right, so take a look at this. Neovascularization. Neovascularization, correct? We have difficult cases, low spherical component, meaning to say if it's in this way, you can see the sphere is only low as 0.25 against a cylinder. Oblique cylinder is also a difficult case. As I've said, if you have an oblique soft toric, is definitely a problem. Or high cylinder, such as -4, 5, 6. Those are high cylinders. So, problem solving. How are we going to do the problem solving? First, check the accuracy of your baseline data. Is your finding correct? Maybe there's something wrong there. Check, double check. Right? Next, interpret. If unexpected power or VA response, good VA, contact lens power is off. Spec RX is off. Your zero cylinder over refraction is off. Or there's lens orientation. Correct? Clear so far? Okay, goody. Next, poor VA with accurate zero cylinder over refraction. It only proves the poor lens fit or the lens quality is poor. Right? Any questions on this? Any questions? None. All right. Okay, let's do the routine for toric soft contact lens assessment. Of course, you have your case history, measure visual acuity, spherical over refraction NVA, spherocylindrical over refraction NVA, check meridional orientation of lens, making sure you understand GLARS or CATs, correct? Then check stability of fit, get patient to move eyes, and then recheck meridional orientation. For mislocating lens, rotate to intended position, meaning to say, for example, it went 15 degrees left. So all you gotta do is just place it in its intended position. If it improves, then you know that it is a rotational problem, right? And not a lens or poor lens quality, right? Use table for calculated angles of mislocation based on the spherocylinder over refraction. Measure power and axis of toric subcontact lens. Measure, meaning to say you are to get the power, right? And the RX through, of course, your refraction. How are you going to get the power, of course? But this is something that you ordered. So check whether what you ordered is the same as your refraction. Measure the power and the axis of your toric contact lens. Is that clear? Then check ocular refraction and keratometry for comparison with basic. All right. Any questions on this? None? If none, thank you very much. I'll see you in the park.
Doc,
Yes.
may ano po ako, may sasabihin po pero pag alis na lang po nung iba.
Kung nakaalis ang iba.
Sige po.